times, and what a start. We've had Sudha Murthy, Kailash Satyarthi, we had the minister, and all eminent doctors are now going on to the next session. And truly, during the times of COVID, that we've realized that the innovative approach, collaborative approach is a way forward to enhance and strengthen our own country's healthcare system. Today, with me are three people who are actually are on the front runners, front leaders, taking India out and fighting across COVID every day. We have Professor Balram Bhargava as a head with ICMR. Everyday decision making during these last 1.5 years that we have been navigating through the COVID, which is where everything of our health structure, fragility, strengths, everything have come. We are learning from it, refining it, taking it forward. We have IMA President, as Isha has introduced, Professor J.A. Jayalal and K. Srinath Reddy, Professor Reddy, also from the Public Health Foundation of India. Public Health Foundation of India has been on ground. IMA has been on ground with doctors navigating COVID work across, not just COVID. I mean, you all do it for all the chronic diseases, acute diseases, all the healthcare problems that we have it across. Professor Bhargava, I would want to come down straight to you onto it. India rightly brands as incredible. And today, the remarkable healthcare transformation over the few decades, we are known as the pharmacy of the world, rightfully said, and which was very evidently, evident to the global thing, where the current research of the COVID genome coming out and the timeline that India could actually indigenously come out with 2 more vaccines and another 3 or 4 on pipelines. This is because the robust healthcare system that we have. How do you think, what strategic approach can be adopted today so that this growth trajectory can be taken across more for an advantage and used for advantage for India itself, for the brand India?
Thank you. At the outset, I'd like to wish all of you a very happy Doctors' Day, and also pay tributes to our colleagues who have lost their lives fighting COVID over the last 16 to 18 months. That has happened across, not only in India, but across the world. Now, to answer your question, I would like to clearly say that India does have a robust pharma industry, and it is a good vaccine superpower as well. Having said that, our healthcare system does need some maintenance and some reforms, particularly in terms of investment. We have only 1% of the GDP on healthcare, unlike many countries where, for example, United States spend about 20% of their $20 trillion economy, which is more than our entire economy on healthcare. So we have, and many countries in Europe spend about 8 to 10% of their GDP. So we have to come somewhere in between and increase our health spending, healthcare spending, health research spending. That would be vitally important to maintain our healthcare structure. We do have, as you mentioned, a robust public health infrastructure, but that is requiring a lot of repair in terms of maintenance, physical infrastructure, in terms of motivation, whether it be the primary health centers, the district hospitals, the medical colleges. And I think with the larger number of medical colleges now, more than 560 or so, with the district hospitals, many of them doing postgraduate courses for specialties like medicine, surgery, pediatrics, gynecology. So these will be very useful if we are able to just give them a new energy. And this is the opportune moment to get the infrastructure ready and in good shape. I mean, they should start, right from their appearance to their performance to their maintenance should be absolutely ensured. I mean, now we are getting a large number of testing laboratories in all the medical colleges. There was one Gazette notification which we were able to get through the ministry on 8th of June last year, which ensured that each and every medical college has a BSL 2 level testing laboratory for all viral pathogens, as well as and that can be repurposed and used for other investigations as well. Similarly, a Gazette notification for setting up oxygen plants in every medical college is also happening, and so these kind of decisions do help in ensuring that the whole infrastructure is maintained. So as far as the COVID-19 program is concerned, and as far as India is concerned, we know we have got now absolutely 2 vaccines, now 4 vaccines, 1 absolutely indigenous homegrown. We have had a rapid testing infrastructure with more than nearly about 3,000 laboratories across the country, testing about 400 million tests up till now cumulatively. And we have been able to, with the help of the National Task Force, we had about 100, and its subgroups, we've had more than 135 meetings over the last 14, 15 months. Actually, it was started on 18th of March, National Task Force, and Dr. Reddy is a member of the task force as well. So, we've been able to take a lot of decisions and give treatment guidelines, update them regularly, and evidence generation for the vaccine, the variants of the various viruses, etc., has been also instrumental in guiding the public health response of the nation for getting. The other thing, the last point here I would like to mention is that we have been using data, particularly the district-specific 7-day average test positivity rate. And this has been very relevant in the second wave, where we have been able to guide the states, the districts, to instate or ease restrictive measures based on their weekly average test positivity rates. So if, for example, today now we have about 570 districts which are less than 5% test positivity rate. So they are really, I would say, in the green zone. Then we have another 82 odd districts which are in the amber zone, or 5 to 10% positivity. And we still have about another 80 odd districts which are more than 10% positivity, weekly positivity. So they are really in the red zone. And therefore, I would clearly emphasize the second wave is not yet over. We are still seeing anywhere between 40 to 50,000 cases per day. So that is very important to remember.
Thank you, Professor Balram. And I would move to Professor Reddy, and you being a part of the task force. We always talk about collaboration is going to be the next key disruption in healthcare. However, when we go down and discuss it across, it's always unclear. Professor Guleria did mention today in the morning that IIT came up and all of it. There are a lot of people from the private sector who would want to be a part of it, be a contributor into doing collaborative. What do you see? How can these collaborations take place, and how can they improve healthcare access? And what is the message that you would want to have this public-private effective partnership?
Firstly, I would beg to differ on the word disruption when it comes to the health sector. While disruptive innovation is something that can be used for technologies, and innovation is certainly required in the health sector, I would like to see it as adaptive advancement, because you have to build upon what is already there, refine those elements, and certainly bring in a lot of innovations for improvement. And there, I believe we do require a lot of partnerships, very purposeful, productive partnerships, both within the health sector as well as beyond the health sector. Within the health sector, it's very clear that we do require a strengthened public sector, as well as a ready and willing private sector, which includes the voluntary sector. That is as far as the service delivery component is concerned, but also to some extent in the public health dimension. Because when it is coming to case detection or vaccination, we do require even the preventive aspects and the public health aspects, both the public sector and the private sector, to have a conjoined effort. But within the health sector, we must recognize that while we generally have seen only the clinical services, we do require good basic sciences as well. Like, for example, the vaccine production that has taken place with an excellent collaboration of the ICMR institutes. And of course, that brings in the other elements also. But we also require public health expertise and also management expertise. All of these are required within the health sector. But going well beyond the health sector, particularly the healthcare sector, we do require other government agencies to come in because there are multi-sectoral engagements that are required for ensuring smooth coordination, not only for a public health emergency, but for influencing the various determinants of health, whether it's nutrition, water, sanitation, many other elements. And with the industry itself, which is again a multi-component industry, we do require much greater collaborations. We need to engage with community-based organizations, elected representatives at all levels. Now the Budget and the Finance Commission have recommended that local bodies, both at the panchayat level and at the municipal level, will be responsible for receiving the funds and managing the funds for primary health care. So you have to engage the local bodies and make them reasonably aware of what the priorities are. And of course, right from local bodies to parliament, you need to engage the representatives as well as the media. So I believe when we're really talking about partnerships, we need a team effort. Whether in football or cricket, you may have individual players of excellence, but unless they combine as a team, it's not going to happen. And I believe, depending upon the task, the members required for performing the task can be drawn from the team based on their expertise. And when we talk about PPP, I would like to redefine it as partnership for a public purpose. Define the public purpose, define the key deliverables, define the accountability mechanisms, and constitute the partnerships as per need.
Thank you, Professor Reddy. I mean, no one could have simply put it across in such simple words that we really need collaboration within the community, within the healthcare and outside also. And the way you've outlined the whole thing, it's so well said. Thank you so much. Professor Jayalal, I'll come down to you. I mean, especially during this second phase, even in the first phase also, what we realized is the crucial role that rural doctors or the peripheral health centers, which actually played across and which is where the connect was needed. How do you, I mean, IM is very uniquely poised today because you have connection to each and every doctor in any of the remotest part of the country. What are the efforts, collaborative efforts are required in a place like India where you have the best of facility in cities, but they could be in the remotest part? How can we, have this access and healthcare access improve over there? How can IMA be the leader there and take it across?
Thank you very much. And first of all, I would like to extend the Doctor's Day greetings. I am also happy to inform Honorable Prime Minister Ji is going to address to our doctors tomorrow by 3:10 o'clock, and he is going to extend the Doctor's Day greeting to all the doctors. With this Indian Medical Association, we have a wide network of 1,800 branches, even in the rural areas. That we thank to ICMR and all the learned colleagues for time again. They are giving the protocols, guidance, and how to go ahead. But making it reachable to the doctors is the prime concern of Indian Medical Association. We are doing it very effectively because regularly we are conducting the Zoom meetings with them and taking that knowledge to them. Both the Ministry of Health and AIMS is helping on this. How do you collaborate that? So whatever when we do, there must be some accreditation or certification or the notification has to be there. The same way what we are trained on the protocols and the evidence-based trial, how to do with the COVID protocol, if it is being certified or accredited by the Ministry of Health or by the National Medical Council that by learning 6 hours on the COVID, they will get few credit hours, and that will in the long run for them, will make some more interest for them, and they will be also able to come forward. And that this proposal we have already given to that. Instead of giving in an episode way of conducting a training, if it is in a structured format, if it is in a way in which we has some tangential output on that, that will be very effectively. And that not always we believe knowledge is power. This knowledge cannot be only the cognitive skill. It must have an affective domain and psychomotor skill. So the transmission of this cognitive skill may be by the Zoom, but it need to be percolated with the affective domain and the psychomotor skill. That can be done only by hand holding or being with them or mentoring with them. So that is a positive effect what Indian Medical Association we enjoy. In a rural area, we have somebody who has an experience of 30 years and 40 years in the medical practice, and he will be able to transmit or in fact the knowledge on the affective domain and psychomotor domain. And more so, one of the big challenge in the rural area and even in the metropolitan cities, what doctors face was an ethical dilemma when there is a lot of patients are coming, beds are shortage, to whom the bed to be allotted, to whom the oxygen to be given. So again, Indian Medical Association played a major role in repeatedly teaching to them and talking to them on the ethical dilemmas which we will face in the COVID and giving them a process. Ethical dilemma, we cannot take a right and left decision. It has to be a process in which they had to come to a conclusion. So that process also Indian Medical Association is able to do that. My only appeal, because all the learned colleagues is there, ICMR is also there must be some structured training program, because the COVID becoming the predictably unpredictable disease. And if they have 5 days, 1 week, a rural doctor can get a training and they will be able to certify that they are trained in the COVID. They have a 2-3 hours study to it. That will have a long way to have the continuing collaboration to go on for this.
Thank you, Dr. Jayalal. I mean, and very rightly said is how IMA is actually hand-holding and mentoring onto it. Now, Professor Balram, you actually had highlighted how at a district level, you all monitored because of the technology. There was a great technology used right from vaccine development to monitoring to knowing the weekly cases so that we could tackle it across. And putting across Professor Jayalal's note on education so that there is a uniformity of prescription, because this time in second phase, I mean, this is my opinion, I could be wrong, but probably you could add on to it. There was at some places probably overprescription or enthusiastic prescription happening, not just by doctors, but because of WhatsApp or misuse onto it. So how technology can help clinician to bridge these gaps so that one, the way education part, which he said during the COVID time, that we can have the rural doctor also as capably trained and probably mentored by the senior thing. So what are your views on this?
I think first of all, technology is good, but technology is not the be all and end all. Technology should be useful for assisting the physician, and technology should help the physician reach the home so that the care can be given at home. But at the same time, many people miss out the most important fact in a doctor-patient relationship, which is a very sacred relationship. It's a holy relationship, and that cannot be replaced by technology. Yes, technology can assist in a big way, whether it be for learning, whether it be for prescribing, whether it be for dissemination of knowledge. Yes, that is very useful. Examples are, for example, I mean, we have a small medical stroke unit on a mobile that goes from village to village, can do a CT scan, or we have a mobile heart attack center sort of a thing on motorcycle responders, which we have started at All India Institute. That could be scaled up. It's a program wherein the technology-based ECG is transmitted by the motorcycle responders, and they are able to give the clot buster medication at home so that the clot dissolves and the heart attack is taken care of. So this, and before that, the ECG is transmitted electronically to the control room where the physician has had a look at it, and the paramedics can give the drug. In terms of over-the-counter and overuse of over-the-counter medications, that is a huge problem, which is a perennial problem only for India, where not only over-the-counter drugs are available, but over-the-counter tests are available. As a citizen, one can walk into an MRI center and get his MRI of any part of the body without a prescription. So these are issues which need definite regulation, and particularly for prescription of medicines, as well as prescription for tests. And they will go a long way once these are taken care of. I mean, the overuse of steroids during the COVID pandemic because it is available over the counter. Anyone could buy steroids and consume any amount without being regulated. So these are learnings from this pandemic, wherein we have to regulate over-the-counter prescriptions, we have to regulate over-the-counter tests. And that will go a long, long way, because what is perceived by an average citizen is that if they get all their tests done, they are fine, they are normal. That is the wrong perception. What is the basic understanding is that there is a difference between a deterministic science and a stochastic science. Biology, human body are stochastic science, where something may be fine now, may not be fine in 5 minutes from now. So you cannot predict anything. The 6 Sigma rule of Motorola does not apply to the human body. And the body has the capacity to heal, while an electronic device or something does not have a capacity to heal. It is either working or not working. So the human body can be, so that is the basic understanding which has to be communicated to the people, that just getting tests is not the answer. Over-the-counter tests should not be should be regulated. Over-the-counter prescriptions should be regulated, and obviously training is always welcome. And I'm of the strong opinion that a good MBBS doctor is able to manage a lot of things, and that is where we need to strengthen, particularly the internship training. And a good MBBS doctor will be able to manage more than 80% of the diseases in the country.
Thank you so much. And so rightly said, training, and no irrational test. I mean, there should be, because we don't know how many CT scans and tumors, thyroid cancers that we are going to see it across a little later. That brings me to Professor Srinath Reddy, and a quick thing that I would want to take it over. What do you think is at the primary healthcare center, the major challenge today? And what do you think about it, and how do we tackle it? Because that's where the challenge of our country is. We have we have a diversity at every level, right from education to access to monetary, everything. So how do you think that and how PHFI can do it?
Well, it's very clear that primary health services, which include care and prevention, health promotion, the whole range, are absolutely pivotal for building a very efficient and equitable health system. And you need that base. Obviously, you need primary health services to be comprehensive, continuous in terms of providing the care. They must be capable of providing both acute and chronic care. And they must be also connected care. They should be connected to secondary and tertiary care for advanced care as needed, and in a reverse flow when people return from there to continue to provide the care that is required. And for that, and including the promotion of self-care and family-assisted care. So all of these elements will have to be built in. And therefore, we are really looking not just at infrastructure, not just at the supplies of equipment and medicines, which are very important, of course, but we are looking particularly at the health workforce who are going to be actually delivering the primary health care, apart from the well-trained MBBS doctors that Dr. Bhargava has spoken of, who are very much required. We do require a large number of non-physician healthcare providers who are technology-enabled. They do not substitute for technologies, but they use the technologies well to bridge the access gap and even the quality gap. So apart from improving the infrastructure right from health and wellness centers to community health centers, you need to invest in the health workforce. And we now recognize that telehealth has come to stay. We must define the parameters of telehealth, how best to utilize it and how not to misuse it, and how to connect it well to primary health care, whether it is the patient or the family member or the primary care provider who is being supported through telehealth services. We need a community connect very strongly, because we have to mobilize the community resources also, whether it is, for example, in COVID, in terms of identifying cases or identifying the contacts or even providing a degree of social support to the isolated families. we require people-partnered public health. Of course, we require emergency transport to take people from home care or primary care to advanced care when needed. So we do require all of that. And I believe if we actually can manage to focus on developing our primary health care services, both in rural areas and in urban areas. Urban primary health care has long been neglected, and that showed up during the COVID pandemic in the initial stages. So we need to actually attend to all of these and build a very robust primary healthcare infrastructure, as well as the health workforce, who can actually deliver a wide range of services, at the same time ensure that their connectivity to advanced healthcare is also fairly robust.
All of you all have actually lined up the entire roadmap, right from Technology Connect to urban, rural thing, education, use of technology, coordination between all the organization, and obviously the healthcare expenditure going up. But if I have to ask you one parting question to all of you all, what is the immediate, actionable, and long-term improvement plans that you would think for a healthy India? Professor Bhargava, for you.
So that's a good question. And the immediate actionable is we're still dealing with the COVID pandemic. So we have to take care of that pandemic and also immediately start our non-COVID services as far as the country and the citizens are concerned. But in terms of policy, I would clearly say, and I would reiterate, that we need to get our public health infrastructure in order. There are hospitals which are not well maintained. There are district hospitals which are not well maintained. There are mohalla clinics which are not well maintained. So they need to be, that infrastructure needs to be robust. The medical workforce needs to be motivated. There shouldn't be any divide between the private and public sector in terms of the remunerations for the public sector healthcare workers, to motivate them to remain in the public system and serve humanity. Because many of them do not move out of the public system out of choice, but they move out because of other pressures. So anyone would like to continue to serve the public health system as long as possible, and therefore it should be attractive.
Thank you, Professor Balram. These questions can go on and on. I can ask Dr. Reddy, Dr. Jayalal, and it can go on, but with the paucity of time that we are facing it across, but all three of you have very beautifully put across the roadmap, which we all, it's very food for thought. We can actually work across all people on board, stakeholders, right from media to government, to doctors, to associations, to NGOs, everyone, foundations can come together and see to realize a healthy India dream for us. And so that we remain incredible healthcare icon, global icon. Once again, thank you so much, Professor Bhargava, Professor Reddy, Professor Jayalal, all of you for taking out your time from this busy schedule. And a warm, warm Doctors Day wishes to all of you and all our audiences. Over to you, Isha. It was a pleasure. Thank you so much for giving me this opportunity. Thank you.
Thank you so very much,
much.
Dr. Mamta Jain, for adding so much value to this fireside chat, and a big thank you to all our panelists for having
Isha, I must tell you, this lecture, probably, this talk, you should actually, this actually gives a roadmap for India's future. Everyone has pinpointed such amazing takeaways. Thank you so much.
Yes, absolutely. And I'm sure that our audience too is registering all of these, taking home some fantastic thoughts there from our speakers. So once again, a big thank you to each one of you for having joined us. Thank you, Dr. Jain, for your best wishes. And this is what we look forward to, some fantastic thoughts coming from our speakers. As we've discussed through the day, this is a very interactive virtual platform. So we want that you should all explore it all the more, network around here. I'd also like to request our viewers to please tweet using our hashtag ETDoctorsDay. And what's interesting right here is that we've, on the one hand, got the best from the healthcare industry from across India right here on this very platform for you. But at the same time, we wanted this platform to have a little bit of fun as well, which is why we've got for you our light moments. We say that laughter is really the best medicine for all. So for all of you, our dear doctors, we've got something that is going to tickle you in the right directions. A very warm welcome to each one of you as you join us for our fun session. I'd like to extend a very warm welcome to Amit Tandon, stand-up comedian who's performed across the globe. He's one of the first 3 Indian comedians on Netflix. He's done various shows on television and is here to win your hearts with his films and thrills. So stay tuned.